this one. Share. And then I also need to share the link to the case. Okay, through the chat, which I'm not sure anymore. Okay, here we go. Chat. Okay, so I think we are all ready. So you should be able to see my screen. You should have received the link through the chat, and then probably we'll go here through the case. As usual, the history is not very long. So it's an older dog, older beagle, vomiting. This is exactly what I copied from what I got. So vomiting, regurgitation, and weight loss. And then I'll show you the images. Oh, okay, and now let's do something else. There is a couple of settings that I need to change every time we do this. Sorry. Okay. So there we are. So two lateral projections. One VD projection. Okay, cool. So I hope we are technically okay. It was a bit of a rush this morning because again I changed the computer and I'm still struggling with all the settings. Okay. So older dog, vomiting, regurgitation, weight loss, and we got a set of abdominal radiographs, which you can look at through my share screen, or you can just download the link and then open them in your computer. Okay, so I think okay, good. So you tell me. We do as usual, the boring thing. You take a look. Then we go through the list of abnormalities. That usually takes us quite some time because we go through things that are sometimes relevant and things that are not relevant. I think for a learning situation, what ends up being not relevant is also very relevant. Makes sense, because otherwise you really never know how your brain reacts to what you see. So exercising that, even if you end up concluding that what you thought was something is nothing relevant, is also a very important part of the learning process. So we are open to everything. And then once we kind of summarize that, then we try to make up a story. We try to, based on what we think is real and really abnormal, then we try to explain, what's happening. And then we recommend what's next. So that's a framework, and I'm all ears now. All good? Nothing abnormal? You are shy?
I'm driving.
I'm trying to bring it up on my computer. The Wi-Fi is really not good at work today.
That's
I can't see anything at the moment. Can you guys see me?
Yes, we can see
Yes.
you.
we can't see your picture.
Well, it depends who's, yeah, okay.
Can you see the radiographs?
Yes.
Oh,
Yes.
Yes.
Yeah.
Good.
Okay, well, I'll stick my neck out.
Okay, well done.
There's a very obvious lesion here on that view, which has got mineral densities through it. Also on the lungs, there's a bit of a density there. And another one perhaps here.
Okay, good, good.
I think also there's a bit of a density there as well.
Okay, good, good.
And on this view, of course, there's the abdominal mass. There.
Good. So I see this situation like if you were all forming kind of a group, and then we have a ball, and then we kind of pass the ball. So you basically you identify some things that you believe are abnormal. I can keep on asking you, but probably it's a good idea also to pass the ball over and to see what the other people think about your comments. Makes sense, because this kind of recreates a normal clinical situation where you see something, you have someone next to you, you ask, and then I think from that interaction, and also I think there is a lot of value from your peers to make comments rather than from me. Makes sense? So I would think about who wants to take the ball and who wants to comment on those findings.
I'll say something quickly because I am driving, so I haven't been able to see carefully, but it's a very obvious loss of serosal detail in those radiographs.
Okay.
That's sort of what I want to add at the moment.
Yeah,
when
cool.
I get to the office, I'll be able to see them properly and maybe add some.
Okay, so that's a kind of a new finding. It's not so much yes, an explanation of the other findings, which is perfectly fine. So we keep on adding, and then we need to see what, if we all agree or if we don't agree. When I say yes, I'm not agreeing, I'm just acknowledging.
With regard to the thorax, so far as we can see in those laterals, I would think that I can't see any masses there in the thorax, but on the VDs on the website that you have, I think there's pleural fissure lines that are not obvious in the VD which we're seeing of the abdomen, but they're subtle. And in the abdomen, I think there's a couple of pieces that looks like a bony foreign material in the stomach, which you can see in a couple of views here and here. But the I guess we can't tell, or I can't tell what this is in because of its location over here. My guess would be if it is in the bowel, it would have to be either displaced colon or the small intestine. But I'm questioning whether it's in the bowel because there is no obvious buildup of significant gas. So I'm wondering if it's extra luminal. But given there's a little bit of bone in the stomach, makes me think maybe it's a compaction of radiopaque material in the lumen of the bowel.
Okay, so a couple of you brought many more many more findings, and some you said to consider how to explain those. So perfectly fine. So from the list that I have, then probably if you go by findings, you added that there are foreign bodies in the stomach, and then you went back to that accumulation of mineral opaque material in the mid-abdomen. And then another thing that you mentioned that I think is very important is that even though you see I think you haven't said it openly, but you kind of question the previous comments about the masses in the thorax, because you can kind of identify something abnormal in the lateral, but you couldn't identify them in the VD. Is that correct?
The VD, which is on the server, that one I could see pleural fissure lines. I just can't see it in this VD. The laterals on the thorax that I can see look normal.
Okay. And then the other important thing is you now started to go a bit further in those mineral opacities. Where are they? And you kind of start kind of brainstorming and saying, well, is that in the bowel? If it's in the bowel, is it in the small bowel? Is it in the colon? If it's in the colon, is it displaced colon? And then if it's in the bowel, there seems to be something that seems not to agree or to produce some noise, and is that the rest of the bowel looks okay. So that's I'm trying to I don't know why I do this, but
Yeah.
trying to make that thinking very, very clear. So probably the reason why I do this is for someone else to be able to attack that or to add, make sense? To make that thing clear. Yes.
I might point out that I didn't say the densities in the thorax were masses. I just said densities. And I don't think they're masses, no. I think they're just perhaps interstitial densities.
Okay.
There's actually is the vasculature there changed? And that
when you were pointing at things, I thought about doing this. So I'm gonna, let me do something else. Because you were kind of hitting three points, and if I remember correctly, the first point was here. Then your second concern was somewhere here.
Yep.
And your third concern was somewhere here. Is that correct?
Yeah, that's close. Yep.
Okay. So I think, I don't think every radiologist, but I personally kind of enjoy coming back to the principles, the physical principles, or what are we actually doing? What are the limitations? And so some people are gonna get sick of me coming back and back to this. I find it very interesting. So you pointed to 3 areas where there is a radiographic principle happening. I'm not saying that is actually what is happening, but just by coincidence is happening. So, which is the superimposition. So I think if I need to be and I want to create an object, so that area seems to be more wide compared to the rest. Okay, so I think that is not that I'm making that up. So if you go objectively, there is something there with that shape that looks more wide. Now, if we need to try to explain and deconstruct that is an area where you have almost kind of the superimposition of 2 ribs. And I think there is the superimposition of the ribs plus the big vessels going to the dorsal lung lobes, plus the esophagus that kind of comes in there. So now you're adding too many structures, and they are producing that area that it looks more wide. It looks more wide compared to this rib, I guess because there is only 1 rib, and there is a superimposition of 2 ribs. Probably here there are not so many vessels. Here is the superimposition of the esophagus that goes there and there with the rib, so it's less wide because there is less object. If you want to keep on adding to that idea, I think in here probably we have a superimposition of, again, 2 ribs. So now we have not 1 but 2, and then probably there is the pulmonary artery is going to be there. So I think we are dealing with the same phenomenon, which is the superimposition. So when we have more objects, remember that early on, we talk about, and I gave you some examples about this, to make something more wide in a radiograph. And one is the atomic number, is the material. So bone is more wide and so on. But another one that is extremely important is the thickness. So basically you have more stuff in this line. That's why it's looking more wide. So in the three areas that you showed up, or you pointed out, there is a lot of superimposition going on. Here we have two ribs plus the esophagus plus the vessels. In this one, I think we have the ribs plus the corvina cava. And then in here we have, I think, the esophagus plus the ribs. So that would be my long answer to what you pointed out. And then I would always come back here and then can we see something? Obviously, the way to make a mistake here is two ways, either not to see something or to see something and believe it's a superimposition. Actually, not a superimposition. It's something like a real lung nodule or something like that, or area of increased lung opacity like pneumonia, edema. And then so the way out is to deconstruct that image and say, what is making that opacity just by following the lines. And then the other one is to say, if I see something there, then I know that it can be anywhere at that level from one side of the dog to the other side of the dog. Makes sense? On the wall, in the breast space, in the lung, in the mediastinum, and so on the other side. So then I come here and I say, do I see something here? Do I see something in the wall? Do I see something in the lung? And so on. So that's a very convoluted way to take your comments. I really enjoy these comments because I think I kind of enjoy this. At the end of the day, it's a limitation of the modality. Makes sense? It's something that we are, an ideal modality, it would be a modality where you can see things as they are, with no superimposition, no artifacts, no nothing. So what I'm saying is a bit crazy because I'm enjoining a limitation. I'm enjoining that something that the modality is limited and is showing us things that don't exist. For some reason, I enjoy that because I know the principle. So then for me, it's interesting. But yeah, it's again a long answer. Yeah. So I think what you're pointing out there is the esophagus.
Okay. It did, the mass, I mean, I was aware of the superimposition, but it did seem to extend beyond the ribs, I thought, where I've put the arrow there. The other thing, the post cava, yes, certainly is there.
Mm-hmm.
It seemed to me, to be an odd shape.
So, okay, so let's keep on deconstructing the image. So remember that the anatomy of the diaphragm is a very complex structure. I don't know if it's so complex. It's very tricky radiographically because it's rounded in every direction, and then not only that, but dorsally it has two components, and then ventrally it has only one component or one border. So what are we seeing? So there are two lines there that should not bother us. So one is going to be the left cruise and the other one is going to be the right cruise. And then I'm going to give you a tip now how to know about that. They should both join ventrally and kind of form one border. Remember that this is just a border of the diaphragm. The diaphragm actually goes more caudally. It makes sense as you go more laterally. So then if I select this area and I go through, then there's going to be a superimposition of many things. It's going to be the wall, the lung. Makes sense? So it could perfectly be a lung nodule here, and then we go and so on in the liver. So coming back to your point about how if this looks odd, so let's deconstruct the image. So we have the border of the corvina cava. That's a ventral border. That's a dorsal border, and then it seems that that line continues. So it's not stopping there and continues and then stops there. And then the ventral border, something similar, goes up to there. So actually that is what we expect. So we expect in a right lateral projection. So in a right lateral projection, oh no, so if this is right, so it's a bit odd. Yeah, so you're right, it's a bit odd because we expect the right to be more cranial. And in this particular case, if this is right, makes sense, right? If this is correct, then this is a bit odd because we would expect in a right lateral projection to have the right crus located more cranially. And then if that would be the case, then the caudal vena cava should stop with the first, as it crosses the first, the more cranial crus, and not extend caudally. So yeah, in that sense, it's unusual. I would probably challenge if this is a right lateral projection. So if this is a right lateral projection, the pylorus should be on the dependent side, and there should be fluid field, and the fundus should be gas field. And it's kind of following that rule. So this seems to be right. This seems to be a bit odd because the more caudal crus is the right, which is odd in a right lateral projection. But it's not odd in terms of the structures that are here. These are the structures that we always see. So these are the lines that they change which one goes more caudal, which one, where it stops. All of that, it can change depending on individual variation and also positioning. But it's not odd in terms of how it looks or the structures that are there. Make sense? Because is the caudal vena cava, is the border of the diaphragm, the ribs are superimposed, is the liver diaphragm against aerated lung. So in that term, if you consider that, it doesn't look that abnormal. Yes, it's interesting. So if you compare both, in both, it seems that the right crus is more caudal. And that is unusual. I take that. Okay, let's go back to the abdomen. And then when you were describing this thing, I was thinking to make this point, to insist, again, on something that is boring, but is remember that when you see something radiographically, you can easily push yourself to the end of what it can be known, let's say, in terms of describing. And so always force yourself to go size, shape, opacity, location, margination. Make sense? So size, shape, location. I forgot the features, but size, shape, opacity, location, and margination. So in shape is probably, well, I think all of those features are relevant here. And then until now, we mentioned I think the opacity is the most relevant thing. And you all brought this thing about this is mineral opaque. I think the location is extremely important in this case. So it's in the right mid-abdomen. We mentioned the mineralization, the opacity. Yeah, and then the size we can measure. The size is going to be important to put in context to try to define what is going on and where is that thing.
It's very well demarcated in terms of margination.
I guess again, if we we use the principle for a reason, because yeah, your point is very good. So what if this, instead of being well demarcated, it would be scattered throughout the whole abdomen? It would be a completely different story. Make sense? So the way that we will try to explain having all of these small mineral opacities, if one thing is if they are all clumped together forming like a well-defined mass. And then another very different situation is if these same small mineral opaque structures are scattered throughout the GI tract, for example, or scattered throughout the abdomen, so the way that we will read these two situations will be extremely different. Makes sense? So I think all of the features, and at the end of the day, they are just morphological features: size, shape, opacity, location, margination. Okay. Anything else in terms of the description, in terms of what do you think is going on, or abnormal findings? Okay, so
I was going to stick my neck out here because I'm not sure exactly what's going on. I mean, I like the idea that it is within the intestine, and I can't say whether it's in the colon or the small intestine, but I'm heading more towards the colon and maybe the ascending colon. But what I'm concerned about very much is the loss of detail. So you've got this contained mineralized density and severe loss of detail everywhere else, which then you've got to ask is if there's something. Well, obviously there's fluid in there and it's leaking, and yet it's contained. So yeah, I'm struggling to see. I mean, you can maybe vaguely see the outline of the kidneys. It's hard to see the spleen. Depends which view you look on. And I can't see the colon other than that mass. I mean, you can see it in the lateral. You can see the colon going into the pelvis, but on the VD, I can't clearly see the colon at all.
maybe there, at least this part. See
Yeah, I'm looking.
there. Well,
Yeah.
because of the granular appearance, and then probably I will try to connect it there, but yeah, I think this is more on the right. Okay, so so coming back to your point, so you were considering, so now you put like very clearly two positions to, and I think it's perfectly fine to say, well, I'm considering these two options, and I'm not sure which one to take. I'm gonna think about what is against, what is in favor of each of the positions, and I may end up being unable to decide still. So the two positions that you are considering, and correct me if I'm wrong, maybe there is a third position, is that seems to be within the GI tract, and then that seems to be accepted. Then the next question is where within the GI tract, and then the two considerations are, is this in the colon or is this in the small bowel? Is that correct?
Yes. And I guess
Cool.
the reason I think it is in the GI tract is because, as Bronwyn pointed out, we've got bones elsewhere in the GI tract. So unless it has ruptured into some extra intestinal pocket, I don't believe it's a mass, like a cancerous mass. I think it's part of the GI tract.
Excellent. So excellent point, and probably too simple, but I enjoy going through the simple. So the simple is not a mass. I suppose the opacity of that mass in terms of that accumulation of elements is not consistent with a neoplastic mass or a granuloma or something. It would be very unusual to look like that. And then your second consideration that you are already saying, I think is unlikely, is, well, can that be that you rupture whatever GI, they look like foreign bodies, so the only way for them to be in the peritoneal space would be, well, what if something rupture? So I think that's a good consideration. The way that I would rule that out, and I would say is elongated. If that's something, if the bowel wall ruptured and then this went into the peritoneum, I would probably not expect them to be also clamped together. Makes sense, because then they would have broken from something with a wall and they will be free in the peritoneum. Even if it's a chronic thing, then they will be scattered throughout. And then if it's an acute situation, then not only fluid, but there should be free gas in the abdomen. So I'm just thinking aloud about, what if I consider that option? What is in favor, what is against? And I can find probably only things against that idea. No free gas if it's acute, it's all clamped together. So the idea of being free in the peritoneum, even if it's chronic or acute, I think is very unlikely. So I like that. And then because of the appearance of the mineral opacities, I think a mass like a neoplasia or a granuloma, I should be careful with what I'm saying now. not explaining. So let me rephrase it like that, like those mineral opacities, those mineral opacities are unlikely to be themselves a neoplastic process or granuloma. Yes, so I kind of agree with you. And then we are still dealing with the situation, is that in the colon or in the small bowel? I suppose the reasoning behind that, or why we be so interested, is if it's in the colon, probably can come out, or it's a situation of a constipation, which could be due to just abnormal or mineral opaque or mineral ingesta, or if it is in the small bowel, then there may be something else, no? And it's not only the ingesta, but there is something else that we need to, that should explain why this accumulation of these mineral opacities. So what would you, so anyone wants to chip in terms of what's your call? How certain are you, and why yes, why not? So is there any position there about, is this in the small bowel or colon? I think both are good considerations. Is there anyone there with a strong position for one option or the other?
I think having pointed out the descending colon earlier, I feel like I can see it where you described it here.
Yeah.
And to be honest, I'm not sure where the ascending colon is located, but I am interested if whether if this is ceco, if this area is cecal gas, does that someone with more anatomical knowledge might be able to assist me? Is that meant to be somehow associated with the ascending colon?
Mm-hmm. Okay, good point. And you are hitting one thing very clearly, and then having that clear anatomical expectation, so it pays off in imaging, you know. So having that expectation about where things should be sitting, I think this is the time where that knowledge pays back. So I agree with you. So let's go through how it should be, and then let's go to this image. So in theory, in a normal dog, then the anatomical position of the cecum and then the ascending colon. So the cecum is always to the right of the midline, and is always at the level of the second or third lumbar segments. So if you go here, it's to the right. This is the first, second, and third. So this is reading the book. And if you go, and it's a bit dorsal in the abdomen. So if you go in this projection, it's usually kind of at this level. And then the ascending colon is a very short segment of the colon that goes cranially from the cecum. Sometimes we don't see it, but I would expect it to be somewhere here. And then we go transverse, immediately caudal to the stomach, and then we go descending, usually almost always on the left. There may be some variations in some animals, but it's never going to be completely on the left, the descending colon. It's going to be, this part is more fixed, and then the more caudal part of the descending colon sometimes may go to the other side and then go into the rectum, but that's the anatomy. So cecum left at the level of the second and third lumbar segments, ascending colon on the, again, on the right side of the abdomen, turns into, and remember that there is a ligament there, that, or a shared meso between the duodenum and the colon. So I think that's the explanation of why that position is a reliable position. Makes sense. So the ascending colon is on the right, then it goes transverse, and then it goes descending. And again, the most caudal part of the colon is more, you know, it can move, but the most cranial part of the colon, descending colon, is more on the left. So that's in theory, and I think having that in mind then helped us make the call in this particular case. So I think based on the appearance of that granular material, I think that's feces in the descending colon. So it's following. So one consideration was, is this the colon? Is that the descending colon? I think it's very unusual. First, because it's in the right, first argument. second argument, because we see something looking more like a normal descending colon, which is in the normal position, which is in the left. Okay, so those would be two arguments to think against this being at least in the descending colon. And then I think this is cecum, and you're right. So if this is cecum, I find extremely unlikely for this to be ascending colon, because ascending colon should be going more cranial to the cecum. Make sense? So, and it goes far caudally, and it goes far caudally, and we already said that it's not the descending colon. So I think now we are having enough arguments, which are all anatomical, make sense, are all about the position of the abnormal structure, and we compare that with the position of what we now identify as being hints of the colon, to conclude that that is very unlikely to be in the colon.
That angle that I've drawn there on the straight red line, to my way of thinking, anatomically, that's the position of the descending duodenum.
Yeah, true. True, perfectly fine. So anatomically, we haven't mentioned that, but then the duodenum has also a fixed position, which is on the right, the descending, and it comes like this, and then it turns around, and then we have the ascending, and then there around that area turns into the jejunum, which doesn't have a fixed position. So perfectly fine. That I will probably buy. I'll probably say I don't have any way to prove you wrong, but I also don't have any way to prove you right. But it makes sense. So it's something that is perfectly fine. I think we have enough arguments to say that that is not the colon. But now the question is, what would you do if you are still uncertain? Because this is going to make a huge difference in this situation. So what would you do if you are in this position, this situation in the clinic? You have the dog on the table, and then the X-ray machine, X-ray table. And then what would you do next if you have that question? I mean, because you don't need to have that certainty. I'm pretty certain, but that doesn't mean that everyone, or I'm always pretty certain. So what would you do next to answer that particular question?
About whether it's the colon.
Yes.
Then you can do a pneumocolon.
Absolutely. Very cheap, very easy, nothing. Just put a little bit of gas into that colon, retake the radiograph. And that's going to be a very cheap, again, easy, non-invasive or minimally invasive way to answer that question with certainty. Okay, so then there's not going to be any question there.
Also go back to absolute basics and get the idea of what it feels like on palpation.
Absolutely, good point, excellent point. Yeah. Okay, so now we are in this point. So from early on, now we narrow down and we say this is likely within the GI tract and it's likely within the small bowel. So now, anything else to comment?
This might be a very silly thought, but like additional to everything else that we've said, part of the other reason that I was feeling that it wasn't large bowel is that there is such poor serosal detail. And if it was in the large colon, I couldn't explain why constipation would cause that kind of change. So then a few things went through my head. One, are they not connected? And it's two concurrent things. And then I kind of looked at the serosal detail, and could it be because of fat related, but the dog doesn't look too fat? Could it be because of like exposure issues and that we're getting false idea of serosal detail? But I thought the lung and the heart look quite good, like outside of the abdomen. So I guess if we do know that it's true poor serosal detail, most likely because of like generalized fluid, then I couldn't see why a constipation like that could cause that, which made me think that it must be more likely in the small intestine, if that makes sense. But that could be very wrong.
So you're bringing a point that is an indirect point. So as long as you recognize that it's an indirect situation, because the reason why it's indirect is because there could be something, if that is constipation, there could be something else explaining fluid. So I would never use the presence of fluid to rule out constipation. Makes sense? So in that sense, there is some indirect connection. But what you are trying to do is what we always try to do, which is if we feel that there are a couple of findings, in this case, and then I go through your thinking about if it's real or not, but let's for a minute assume that it's real and there is free fluid, then what you're trying to do is try to put all the findings together. So an easy or a way that would fit better would be to say, well, that's not in the colon. There's something in the small bowel that is producing both the fluid and that appearance. So then it seems then it's easier to group the findings together. That's what we do all the time. And we always need to be very careful about how much we force to pack findings into a nice story. And the only danger, I love that, the only danger with that is that we conclude that thinking process too early. And then we fall in love with an idea and then we don't consider other options. Hopefully my answer. So in terms of the loss of cellular detail, I like your considerations. The animal is not, it's hard because it's not too thin, but I think there is not a lot of intra-abdominal fat, but there is enough. And then the exposure, I would say more than the exposure is the technique. This is not DR. Now we are getting very used to the DR, which is a lot more contrasty. This is CR, which is less contrasty. So I think that is that is playing a role. But at the end of the day, when I look at it, I don't think there is a lot of fluid because the volume of that abdomen is not increased dramatically. But I think I would entertain the idea that there is a small amount of fluid. Again, after considering all of the other things, is it a fat dog or not, how much intra-abdominal fat there is, and then the technique. So I find this case difficult in that regards, like being certain about the fluid. And after wondering, going back and forth, I think I like to conclude that there is I would think that there is a mild amount, not a severe amount. Okay, anything else to say about that accumulation, that clumping of small, because I want to challenge you. Let me invite you and challenge you with this idea. So if we have a dog that ate a piece of bone that is this big, make sense? Whatever, a horse bone, like a horse hoof. Like the other day we had a dog eating a horse hoof, or if you eat, like, I don't know, let me think, any other foreign body that is on itself that big, then we can explain because it's one object, it's a focal thing. The problem that I have with that idea, which I'm not sure I was clear enough, this seems to be clumping of a lot of small foreign bodies. So my question is, why are they not going through? Because one thing is to deal with one big foreign body, and I don't know, I'm running out of ideas, like a rock, or like a tennis ball, or a horse hoof. So in those situations, then the structure is big, I can go through, and then obviously it's going to produce an obstruction, the dog is going to be vomiting, and we know that, we see that every day. This is a different scenario because there are multiple small ones, and if I take each of them separately, for instance, so if I take that, I would expect each of them to be able to transit through the small bowel. So how are you going to react to that challenge?
Well, it looks more like an impaction of the bowel, like when they eat sand or things like that, that because of the consistency, it doesn't really pass through the bowel very easily. But I don't really know how to explain the mineral opacity though.
But you are still blaming the content. So you are still saying for some reason that content, and I would still challenge that because, for example, there are more. So it seems that the owner is feeding bones to this dog, and there are more bones coming. Makes sense. They are in the stomach. And this one, made it up to there, and then it obviously stopped because it can go through this. And then if I even take your same example about the sun impaction, I think there's a paper out there where the best thing, or I don't want to say something that's not right, but I have in mind that one of the ways that you can treat medically and slowly go through. So I accept that there is going to be clamping and there's going to be some distension of some bowel loops, but slowly the picture is a bit different. So there is not a focal accumulation in one point. There is an abnormal bowel, but a very slow transit. But basically it's transiting, it's going through. Here it seems to be boom, just kind of one stop. And then there is a place where for some reason, multiple small foreign bodies that they are small enough to be able to transit through the GI tract are failing to do that.
Maybe they're inside a plastic bag or something.
Yeah, that's what I was going to say.
I was
Or
thinking it might have been
netted.
stock or something like that, then is trapping the pieces of bone. But the other thing that interests me is that there's an even border around there, well demarcated, where this one, it's a lot more ragtag. So's my drawing.
Okay, so you are considering, and I can. So it's a good idea. So to say, well, now there's not only this small mineral opaque foreign body, but there is another foreign body which is likely radiolucent. That's why we can't see it. That foreign body that is radiolucent that we can't see is producing an obstruction, and then because of that, then all these small foreign bodies are unable to transit through the GI tract. So that seems to be one of your ideas.
Yeah.
Do you have any other idea along those lines?
The other thing I was thinking of is a potential stricture or mass in the intestine or something like that. That's like the same concept as a foreign body that we can't see, but something that's narrowed the lumen so that they can't get through.
Excellent. That is it. I would say that's the way that we like to think about this. Okay, so we don't see. That's why today when I was mentioning and I was saying neoplasia, I said, well, actually those little foreign bodies are not the neoplasia, but they are somehow the way that we read this. So I'm going to expand on this idea. So the way that we read this, we call this gravel sign. Makes sense? And I'll give you some kind of a very small definition. So you remember that we have radiographic signs and all of that. So this is a very classic one. So if you're gonna go through the membership or whatever, this is extremely, it's a very well known and something extremely useful. And once you see it and once you understand the principle, then it's very cool. So it's called gravel sign, and it's the accumulation of small mineral fragments of ingesta that may develop proximal to a chronic partial obstruction. Okay, so this is key. If it's a complete obstruction, if it's going to be acute, probably not enough time for those small foreign bodies to accumulate. Make sense? If it's a chronic and it's partial, then fluid can go through, and then those little ones that could go through an otherwise normal GI tract now are unable to go through because there is a focal narrowing. Make sense? So that is a principle. We call it gravel sign. We always, this is the mother of them, it's a very, very cool case. The considerations are always the same. Is that in the colon or is not in the colon? That's going to change. Once you rule out the colon, then if you deal with this and you conclude that it's in the small bowel, then I think you need to conclude that at least there is a possibility of a gravel sign, which means that there is the possibility of a focal chronic narrowing or mural lesion or foreign body, or it is a partial obstruction in the chronic partial obstruction in the GI tract. Makes sense? And that is this is the result. This is the result of that. And if we put this in context with the history that I gave in the early on, this is an older dog, and I think it had chronic vomiting. So I think this kind of makes it a very nice So vomiting, not chronic, but weight loss.
Weight
That
loss,
gives
yeah.
chronicity. So this is exactly what I took from that. That this is a real case, and I remember I just copied what we got. So everything kind of falls in place. And then the next question for you is, what would you do next? Having that ultrasound, good. So we run ultrasound images are not great, and I'm not sure it's the same day because there's so much fluid there. No, it's not the same day. So I need to go through this one. And the reason why ultrasound is because now we want to document. Now we want to see that wall, that wall or that lumen. Is there really a foreign body there, a larger foreign body that is partially obstructing? My experience is that even though I think we cannot say never foreign bodies, this is usually secondary to a chronic mural lesion. All the ones that I remember seeing are secondary to a lesion in the wall. And again, that lesion in the wall it makes the wall of the bowel thicken. The lumen, therefore, is narrower. There is usually less compliance, or the bowel cannot distend. And then the lumen, there is a focal narrowing of the lumen. So that's the classic case. So there was fluid. So this is in between the liver lobes. So there was a little bit of fluid, and then I think that's very likely the foreign body. Oh, sorry. That there is a hyperechoic thing with a shadow that is either the colon or it's just stomach. Okay, so there's some gas. Okay, stomach. So stomach. So this is the GI tract. So oh, Mariano. So when we find something like this is the kind of the hallmark of something abnormal in the lumen, because first the diameter of the bowel is too large, so it's distended. The wall there is not too abnormal, but the content is abnormal, is hyperechoic with a very clear shadow. So that's not gas. That's what we call a foreign body. In this case, I think this is exactly on the gravel sign, on the gravel. And then let me just jump to the one where we documented the abnormal wall. So what are the findings? Okay, so here we go. So this is it's hard to explain on ultrasonographic image, but this is the bowel wall here. This is the lesion. So this is the lumen, I think. This is part of the foreign bodies, hyperechoic with a shadow, and this is the thickened wall. So if you make the bowel from here to here, okay? So in a normal situation will be the wall very thin, and then the lumen, and it will not be so distended because it's functionally okay and the content will go through. In this situation, what we see is this is the outer contour there, and then the lumen. Let's use another tool. The lumen is this, and then all of this. Oh, this is not a good tool. Let me see. So open. So I think this is the lumen, and then this is all thickened wall. Okay. So and these guys, these foreign bodies, hyperechoic foreign bodies, are unable to go through. So this is basically what we are after. This is, if you think about ultrasound and challenges in ultrasound, this is a challenge. This is a challenge, probably not so much because there's so much content in that bowel that I think if you have a little bit of experience, you will be able to see that. And then your immediate reaction will be try to follow that cranially and caudally, because what you're after is to find a focal area of abnormal wall. And in this case, so this wall is very thickened, no layers, and results in a very thin lumen, and then the accumulation of hyperechoic material on one end of that. Again, sharing ultrasonographic images and even static is hard, but that's the principle. So the principle ultrasound is going to allow you to judge the wall, the thickness of the wall, the layering of the wall, to separate the wall from the lumen and the outside, the serosal contents. or serosal deperitoneum, or if there is fluid. And then it will allow you to make this call, which is basically what you want to document after seeing those radiographs. And again, so if you are, like I remember Alex, so Alex, if you are thinking about members, this is, I'm not saying that it's going to be in the exam, but this will make a very, very, very cool exam situation, because it's a very well-known radiographic principle, and there is some knowledge that we need to have, make sense, when we see that, at least to consider.
Yeah, no, awesome case. Thank you, Mariano. I will definitely remember this for members.
Yeah, well done.
And
You have a
it kind of
spot
makes a lot of sense once you understand, what's the principle. Now you can see, there is a focal area of the wall is focal thickening of the wall, the lumen is narrow, and then the dog is eating bones which are partially digested. That's why they are so small. I don't know if you realize that the bones in the stomach are larger compared to these fragments. So they are being digested as they go, as they should. Like in a normal dog, this would be all scattered. So so in a dog that is eating bones, how is this different from a dog that is eating bones and is a healthy dog? Well, in a dog that if you feed bones, they're gonna get, digested, like we see that happening in the stomach, and then there will be all of those mineral opacities. They will be scattered throughout the GI tract, and then so will not accumulate. Another point that someone mentioned about why is not the small bowel distended, and that's a beautiful question, and I don't know exactly, but probably I come back to the principle of this gravel sign, which is a partial obstruction. So actually, if we believe that this is the small bowel, makes sense, which we now believe and we documented ultrasonographically. So actually, the small bowel is distended because that is the small bowel. So that to start with. And then the second is, why is no more distended? Why there is no more small bowel distension? And I guess there are two possible answers there. One is that that's actually the duodenum. Makes sense? And then the obstruction is so high that then the rest of the small bowel is empty. And then in that case, the dog is vomiting, and that's why there is not so many, the stomach is not so distended. And the other possible explanation is that this is a partial obstruction. Makes sense? So all the fluid is able to go through, and then there's just the accumulation of these mineral opacities. Okay, we went over. Again, this is I don't know, when I was trying to find that case, I found this, and this is
my attention lapsed.
It's a principle. Yeah.
Lapsed there for a bit. Sorry, Mariano. It was a neoplasia, was it?
Yes, I think it was.
Yeah, because that fits, like an old dog like that's more likely to be neoplastic than foreign body.
Yeah. And then I went fast through the ultrasonographic images, but there were nodules. So there was free fluid, which explains why. So the free fluid is not because it was a perforation. The free fluid is because it's free fluid secondary to a neoplastic process. And then I went fast through the ultrasonographic images, but there were nodules, I think in the spleen and in the liver. So this looks like a neoplastic process with mets and free fluid.
Okay.
Which is, again, it makes this a very, very nice teaching case, because this is basically how it presents. Makes sense? Makes sense? This is the gravel sign, is secondary to a chronic obstruction. So it doesn't necessarily have to be secondary to neoplasia, but that's the most common situation. In an older dog, then neoplasia is the top differential. In this case, there was neoplasia, there was free fluid, and there were mets. So all of that. And then it's a beautiful case to compare what we see radiographically and what we see ultrasonographically. Makes sense? And again, they kind of complement each other. So this is a beautiful example of our radiography giving us so much information. And then we complement that. The next step is to do ultrasound. Okay.
Very
Tina,
good
wants
one.
to-
Thank you.
Thank you. That was a great case. Thank you,
Yeah,
Mariano.
it was brilliant. We
Awesome.
learned
So
lots.
we'll see